Welcome to Perspectives with Pinnacle, exploring the evolving world of healthcare. Let's navigate complexities and unlock new perspectives together.
Hello and welcome to Perspectives with Pinnacle. I'm John Carter. Today's conversation will be Coordinated Value, Conversations on Value-Based Enterprises and Tomorrow's Care Models. I'm joined by two subject matter experts in the space, Pinnacle Healthcare Consulting Partner and Strategy Division Leader, Anthony Long, as well as a good friend of the firm, Jim Burke from Hall Render Advisory Services. Gentlemen, thanks so much for joining us.
Thank you, John.
Yeah, absolutely. So, guys, I know we've done several presentations on value-based enterprises, mostly at a high level, everything from ACHE Congress to our recent presentation for the team model. We've also built several value-based enterprises across the country for different clients on different initiatives. One of the things that I've noticed is that at a high level, people have presented, but nobody's really taken the time to break down the characteristics, the strategy, or a roadmap for implementation to how to successfully develop and stand up one of these models. So today I thought we might take a little bit of a deeper dive. One of the things I'd like to start with is the difference between how some people are using VBEs as a tactic versus a strategy. Could you maybe take some time to break down the differences between the two and what you're seeing across the country?
Yeah, John, happy to. So as we go through and we talk about different physician alignment models, whether we're talking about call and medical directorships or some of the other joint venture co-management agreements, VBE has definitely allowed us to think about it from a strategy perspective, and that is everything from governance to physician involvement, alignment, collaboration with our providers, collaboration, frankly, across our executive team and the different middle managers. And it's really given us an opportunity to elevate the strategy overall from just a overall alignment opportunity.
You know, it's interesting, Anthony, as we've worked together across the country on these, we sometimes have clients that are looking at it really predominantly as a strategy. We're going to use VBE to do things we just weren't able to do in the past. And we have other clients come to us and say, hey, we've got an issue that we need to resolve. We've got some concerns here with engagement with physicians, and we'd like to talk about how a VBE might help iron that out. And so we really do get the spectrum from strategic initiatives to just simply tactical application of another stark exception. And so really runs the gamut of what we see across the country.
Yeah. Well, and John, I think we'd be remiss if we didn't talk about just the physician involvement aspect. I think there's often discussions about physician alignment and what it means, and yet we fail to ask the physician. We fail to get the physician involved, coming up with the ideas and really having those conversations with the people on the front line and the individuals that are leading that care is so critical, and we frequently miss that.
Yeah, we do see across the country the VBEs that seem to be really taking off and be successful are the ones that recognize early that physicians are in a unique position to help redesign the care model. And so, when you turn over to physicians, not just the actual care delivery, but the model and the thinking and the planning behind how you're going to deliver care systemically, they really are amazing what they can do when you engage them appropriately.
And, I've seen some people that are really using a VBE, and not to say that it's a golden ticket, right? This is not a get out of jail free card, but I am seeing people that are using it much more as a belt and suspenders to kind of overlay with a little bit more protection and precision some of the tactics that they're already currently using, whether that's in the co-management service lines. But some of the more forward-leaning organizations, more of an enterprise strategy as they look at physician comp design, as they look at alignment, as they look at bringing in post-acute. What are you guys seeing on both sides? Maybe talk a little bit about kind of that belt and suspenders approach, and maybe just from a strategy perspective about really creating alignment and bringing in those participants.
John, I think you have those that have said, and Jim alluded to this, you have those that have said, hey, I'm in trouble with my compensation design. I'm in trouble with my compensation plan. Maybe that's because it was poorly designed to begin with. Maybe that's because we've been too aggressive with physician comp. And so there's been those that have used the model to say, hey, let's help me get out of trouble. And that's not really the goal with the model. I think strategically thinking through how do you elevate the value-based enterprise model to actually get physicians involved, kind of keep them engaged and involved in the process, whether that's a a process metric, whether that's outcomes, whether that's redesigning, as Jim alluded to, the care delivery model. It's really fascinating what's being created.
Yeah, and it's interesting. We see at Hall Render, some of our clients are fairly conservative about how they implement some of these care delivery models in partnership with physicians. And I would say that actually some of our more conservative clients who have been reluctant to fully embrace VBE are probably the best suited to do so. And so really that when you say belt and suspenders, that always reminds me of conversations we're having with clients. You don't have to give up your fair market value analysis. You don't have to give up your commercial reasonableness analysis. There's no reason, however, you can't layer in VBE on top of this. And it really can be used. One of the, we'll talk later, one of the purposes for VBE is to help transition from models that pay based on volume to models that pay based on value. And layering in VBE on top of a compliant, well-run system is a great way to get started in that process without necessarily jumping off a cliff and forgetting about fair market value.
No, I think it's a great point. And one of the things I've seen is value-based enterprise has been a little slow to roll out. I mean, obviously they came out in kind of the era of COVID, and people were, in the middle of a crisis. But now we start to see kind of that law of diffusion of innovation where we started to create that penetration and more people are starting to look at it. I think one of the challenges is that it's not as black and white as some of the other regulatory requirements that have been laid out. And so when you start talking about volume, when you start talking about referrals, people were looking for very crystal clear guidance from the government. And I think the government kind of took a little bit of an approach of a hands off, like go and innovate and let's figure out how to move this model forward, especially as we look at more innovative models and some even mandatory that are coming down, like Team or some of the other ones like the ASM model and Wiser model that'll be coming out. And so what's really interesting to me is when we take a deep dive, I'd love to look at this through an operator's lens and really talk about some of the characteristics of a value-based enterprise, maybe look at some examples in terms of how you develop and build out that roadmap. So from your perspective, when you look at kind of the clear objectives, both clinical and operational, what are some things that come to mind? And if you're working with organizations, how do you help pull that information out to lay it on the table and start to really break down what it's going to take to build this framework?
It's really interesting, and I've heard Anthony talk directly with clients about this subject. And as we look at how you're going to launch a successful VBE, it takes a lot of forethought and planning, and it really takes getting physicians involved early and targeting what it is you want to change. The regs have a really easy outline to follow, but the starting position is what is it we want to have change? If you're starting with, I want to change my market share, I want to change my volume, I want to change, you've probably got a lot of work to do to swing that around to something that's going to be compliant and meaningful. If, however, you're saying we're really not giving patients the care that we'd like to in terms of continuity of care or outcomes down the road, you're really you're on the right track. If you say I want to engage with our physicians in a better way, we're in a bad place with our physicians, we'd really like to collaborate with them better, you're on the right track. And I've heard Anthony work a room of physicians and administrators and start out on opposite ends of the room ready to kill each other. And there's a lot of work bringing them together, but that's what VBE is really so good at.
Yeah, absolutely. It's like Stephen Covey would say, right? Start with the end in mind and then work backwards, understanding what you want to accomplish.
Well, and I think unlike Stephen, there's a lot of folks that don't know what they want to accomplish at the end. They just want it to be better. And so they don't know kind of the starting point. They don't know kind of the next steps. I think there's a lot of trepidation around when you start talking about care outside the four walls of the hospital. You haven't always had the models in the past to be able to deal with that. So to think about not just the outpatient side of the hospital, but to think about the ambulatory side of the physician practice, to think about long-term care, to think about transportation systems, to think about new innovative programs that now we have the ability to elevate. It just has not been an opportunity really to explore those, and the innovation that's coming out of these discussions, pretty incredible, where we want healthcare to go versus where it's been historically.
And when you're engaged with physicians, they're very busy. They're extremely intelligent. They're under a lot of pressure. We keep layering more and more on them. The next BPA that fires to tell them to do something in the middle of providing care. And it really does help if you get specific fairly early. And I don't mean down to how many dollars and which metric, but what it is you're trying to achieve. Are you talking about pre and post acute care? I'm thinking about clients that have transitional care management numbers that are horrible, right? They can't get 50% of their patients into a TQM visit within 7 or 14 days. You bring that kind of a problem to a physician and say, or a group of physicians and say, our patients aren't being discharged and then seeing someone. What do we do about it? Physicians can help you solve that problem.
Yeah, I love that. Well, and that kind of leads to the next point. So we talk about shared governance, we talk about risk, we talk about reward, collaboration among participants. What does that look like? What are participants? Obviously, physicians are going to be involved. There's going to be some leadership. But when you look at who needs to be involved, and one of the things I think that is a little bit of a misconception is when people think of value-based enterprises, they think of, oh, this is like a SIN, or I have to create another formal entity, or I need to have another tax ID. And I think they probably did themselves a disservice by not just calling them value-based initiatives. So let's just look at it initiative by initiative. But what do you do? How do you determine who the participants are? How do you determine who should be involved in that process? What does that look like as you go through that planning phase?
Yeah, I don't think you can cast the net wide enough. You really do need to have the individuals that are going to be involved in the process that have the ability to pull the information, to report the data, to think through a process that starts maybe in the physician's office and extends through surgery, extends through kind of the acute care visit and ultimately to that post-acute, whether it's talking about the team model and 30 days post-op, really thinking through that carefully and who's involved in that process. You don't have to have 60 people sitting around the table, but you definitely have to have operators. You need to have the executives that can actually make the decision, not those that say, hey, I have to go back and talk to my boss and figure this out. So kind of thinking about that from a multi-prong layer. If compliance is part of that discussion, nursing care, physicians, of course, need to be at the forefront of that. And not just asking the physicians their thoughts on it, but actually implementing their ideas is a big change from where we've been historically.
Absolutely. And, I would add to that, Anthony, that this is a great example of form should follow function. What we're going to write down on the paper that encompasses what our VBE is should actually mirror who we're inviting to the table and what we're going to do through this process of the VBE. And I can't stress enough, don't shortchange the accountable body. That governance process is important. So you go through the steps that Anthony just described, and then you pick a governance model for that VBE. And we're seeing lots of different models around the country. We have, large national healthcare systems that are creating centralized VBE models that govern that accountable body. And then they have committees that report up to them on specific initiatives. It's a big, complex model. You don't have to go that route. But you got to invite to that accountable body the folks that Anthony just talked about, whether you're doing a centralized governance model or a separate governance model for each individual VBE. Either way, you've got to have the operators, you've got to have IT, you've got to have, in addition to the physicians, you've got to have the folks that are going to be contributing to the success of that.
What's amazing is that it's actually working. So we have in those, I think there's always this hesitation that if I give up control of governance or I invite some busy executives and busy physicians and busy operators to sit around the table that, the first meeting is going to go well. Everyone's excited. They open up about the agenda. They have some good discussion, and then it's going to fall off. We've seen just the opposite. So having that ability to really get involved and bring up the issues and actually have a forum to have conversations about why something is not working is as valuable as talking about the end in mind and where we want to get to. So kind of breaking that down into pieces and having the full team around the table. Full team may be 6 individuals in the entire health system. But again, having the right people around that table is very important.
And that just depends on each additional initiative, right? So identifying the initiative, identifying who needs to be at the table. And one of the things that resonates from what you're telling me is to trust the people that touch the process. So this is probably a great opportunity for your process improvement team to come in and look at some agile, look at sprints, look at different things from a lean perspective to really help monitor the process. But it sounds like that engagement from the front end is what's driving that success across the continuum, and not just another flavor of the month initiative, not just to check the block and move it over to a file and file it away.
I think the other aspect of that is not just involving everyone that you would immediately think of is, so do I involve my medical director of the OR? Maybe they have the personality for that discussion. Maybe they don't. Maybe they have the strategic mentality. Maybe they don't. Having the right people around that table is critical to evaluate on a per organization perspective. So it's not always the health system CEO. Sometimes it's the COO. Sometimes it's the regional hospital director. But being smart about that, same aspect of the physician. Just because the most popular physician has been at every meeting before doesn't necessarily make them the right physician to be at that table. So being mindful about that, I think, is critical in forming that governance structure.
And I do think it's an important point you make, John, about the reference to Lean Six Sigma. Whatever methodology you're going to use for change management, that's what a VBE is supposed to be about, change, right? You're supposed to be picking something you want to change in order to provide either better quality, lower cost to payers, transition to volume, from volume to value, or better care coordination. So you pick one of these purposes and say, we're not doing this in the way we want to do it. Now you're on to change. And so early involvement of all the stakeholders, clearly defining the problem, making sure you can measure what you're going to try to change, the activities you're going to, those are all part and parcel of the regs through VBE. So it's a great analogy or great reference to that change management process. Whatever you use in your system, whether it's Lean Six Sigma or some other methodology, that's what you need in the VBE.
Right. Well, and I know that we have other presentations. If somebody's looking for a kind of a high-level overview of the components and all the things that go into a VBE, we can certainly provide that. But from a regulatory flexibility perspective, when you look at some of the Stark exceptions, the anti-kickback, safe harbors, it does give you a lot of freedom. But where I think the real challenge for me is understanding the development of the metrics, because going to your point, right, this can't be about volume. It's not just about saving money. It's about cost. It's about quality. It's about outcomes, patient-reported outcomes. So when you're looking at metrics, how do you help determine what those metrics are? Are they as broad as reducing hospital readmissions, improving HCAHPS, standardization of preference pack for cost reduction, or is it a lot more nuanced and kind of step-by-step aligned with those activities? What does that look like from a high level?
I tell you, it's one of the reasons I like working with Anthony on these projects, because from the regulatory standpoint, it's very clear you're supposed to have outcome metrics and process metrics. The regs say that, and the commentary to the regs really dive pretty deeply into what that means. And so, it's not like a typical Stark exception where you've got an inch-thick file that you've papered with all of the documentation and the third-party opinions and all of the details that prove this is going to be a compliant arrangement. That's not what a VBE is. A VBE is a promise that you're going to do something in the future that will lead to a result that's worth setting aside the Stark requirements. And so it's really the devil's in the details, and that's where Anthony really has been instrumental in some of this work to come up with those details, process metrics, outcome metrics, and you have to have both, and they have to be clearly defined before you get started.
Well, we do call him the physician whisperer, so.
There are, John, I think it's all those things you mentioned, and I think to Jim's point, you really are kind of working through the process and saying, let's be mindful about it. There's some areas that hospitals and physicians have worked on for years that have progressed, and we've made great strides. And you walk into the next health system and you realize, boy, you're 10 years behind. So if we're talking about length of stay items with spinal surgery or some of our cardiovascular procedures that have largely moved to outpatient care, and we're still keeping these patients 2 days, 3 days, and allowing kind of that weekend, patient to stay in the acute care facility for multiple days, it just doesn't work anymore. We've got to be mindful. We've got to be more innovative, thinking through those metrics in a way that says, let's step back. Let's understand what we do well. So let's get the outcomes metrics. Let's talk about how we're performing, at least from the government's perspective, maybe on a registry and how we've reported that information. And then let's identify where we stand out. Where are we not providing either good reporting, which is always an argument. We always get into the debate. It's the wrong data. It's not reported correctly. Someone must have put the data in wrong. But then stepping back and saying, let's look forward and understand where we want to get to. So once we get past the data pieces, let's understand the items that we really need to make a change on.
You know, it's interesting because you talk about all the reasons that these types of initiatives have failed in the last 20 years. And we've seen so many failures, right? We've seen more failures than success. And so you work for months, years to put together a program to try to start an initiative, and then you come back 3 years later and nothing's changed. And I would say one of the things that has been frustrating in the past has been the notion that we put in all this time setting up an initiative for changing something in the delivery of care. And then at the end, we get back an opinion that says you can pay the physicians this much for this many hours of work. And so that's how we're going to measure the success of this program, is how many hours the physician puts in on a timesheet. It never works. Instead of the inputs model, VBE allows us to switch to an outputs model. What change are you actually creating? What success are you creating? And pay physicians for that success. And under the previous regulatory framework, that was illegal. And now what was illegal is actually being encouraged. Partner with your physicians, pay them for outcomes, make sure it's related to a worthwhile and permitted purpose, and track and measure. And you've got a little bit of safety here in doing things that we couldn't do before.
Well, and I think, John, you brought this up before, and to the point Jim just made, I think there's a lot of hesitation because the government did not specifically state you can do this, you cannot do that, which was a complete shift in thinking and what we're allowed to create and what we're allowed to innovate around. And so I think hospitals have struggled with this, probably more so, to be honest with you, than physicians, because physicians are looking at it from an outcomes and process. Hey, we've been talking about these things. How do I elevate care? I think hospitals have historically looked at kind of that legal and regulatory, the fair market value perspective to say, I have to prove, you have to attest, physician, that you've spent this many hours or I can't pay you. This is an opportunity to kind of change that mentality and usually use the value-based enterprise as a strategy versus a tactic. Yeah. Because now I'm elevating and I'm not just counting hours. I'm actually paying based on my work towards an implemented solution that raises care, raises value.
You know, that's it's interesting because you look at some of our best clients, some of the ones who would succeed the most with VBE have been reluctant to move in that direction. And it's this combination of telling them that they no longer have to prove up fair market value or even potentially commercial reasonableness. And if they're in a VBE that has meaningful downside risk for the physician, they don't even have to worry about whether or not the metrics and the pay could potentially be tied to volume and value of referrals. That's a dramatic departure. It's 180 degrees from what they've been hearing for years. And then at the same time, the regs are so unclear about what exactly is permitted. They're so open-ended. So that combination of you can kind of set aside everything you thought you knew to do something that's completely undefined, choose your own adventure. That combination has really, I think, slowed the implementation of VBE around the country.
But I think that's the exciting part, right? Is so instead of thinking about just the pure blocking and tackling and thinking about the structural components of the FMV and all the regulatory requirements that go into documentation, this is kind of, getting out of the battle and getting up to the balcony and saying, look out over the battlefield and let's figure out how we can win the war, and let's figure out how we can make this more, make it better for our patients. And so what do we need to do and how do we go about doing it? Let's really solve the problem and not think about all the back end stuff. And once we've identified the problem, we can build the framework that supports all of that. But this kind of allows us to get a little bit more higher level, to your point about being elevated. And so one of the questions I would have, I've been fortunate, been in value-based care since kind of the beginning. I just fell into it. And I know some are much further along than others. We see a lot on the coast, a little bit less in kind of the heartland center of the United States. But I, at least in my work, have seen that this is a really good opportunity to get some of the laggards on board and realizing that, the models are moving this way. And this is a great opportunity to reframe that thinking. Are you seeing a rise in some of these organizations that have historically not been involved in value-based care? Or is this mostly to this point been people just taking value-based care to another level?
Well, I think it's a transition. So I think there's organizations that have had to understand and get educated that this isn't about creating a ACO or creating a CIN or this big lift, or they dismiss it, frankly, because they say, I already have one of those. Why would I do this? And so I think it has brought more people into the value-based care model, preparing them for the mandatory models, which we're going to talk about, and some other models which are being released, it seems like daily or weekly. So I think it's a transition to position organizations to say, hey, I really have an opportunity now to get to value and not just focus on fee-for-service and volume. But it's just that. It's a transition. It's a step along the way. It's a journey. It's a roadmap, so to speak, of how do we get there? How do I align with my physicians and my providers outside my organization to really impact care? And I think it's having a dramatic impact. It's not a conversation we're having, but we're actually seeing results. It's a momentum. Let's show a small success, which builds on kind of that intermediate and ultimately moves to the end game, which is what we're after.
Anthony, it really is a transition and kind of a spectrum of how people are using it. I'd say 2 years ago, John, we were seeing probably 3/4 of the VBEs we were writing were, in reference to Anthony's comments, they were to solve a problem. We have a compliance concern. The way we run this relationship has gotten out of line with our original paperwork, and we just are uncomfortable with it. It wasn't necessarily clients who had a terrible failure under Stark. It was just that they were concerned and they wanted to switch to VB as a way of addressing those concerns. That was the bulk of it before. It's a new Stark exception. Let's use it for very tactical problem solving. We want to move away from something that keeps us up at night. The other end of the spectrum, maybe a fourth of our work in that space, was our most forward-thinking clients who really were saying VBE is a chance to finally do things that we weren't able to do before. Those really strategic initiatives where VBE is not just a Stark exception, it is a strategic overview, as you say, from the balcony of everything that's going on. What's exciting now in that transition that Anthony's referring to is to start seeing health systems use it for smaller, somewhat strategic initiatives that they just haven't had a tool for in the past. So it can be really simple things like on-time starts in the OR,
Wouldn't that be nice?
Yeah, wouldn't it?
And maybe not exactly easy sometimes.
Yeah. Simple, not easy. There's a difference. And so, getting the surgeons and the anesthesiologists to actually coordinate and work together, and who's running the board in the OR, and some real practical daily issues that can improve care coordination, can certainly help a system prepare to be at risk for the payment for these episodes of care, which we're going to talk about here. But that narrow application it's still a strategy, but to a smaller scope. We're writing one physician VBEs now that are really amazing, the types of things that we're engaging physicians to lead on behalf of a health system. So it's really fun to see the kind of implementation of that across the spectrum.
I think the struggle that we are seeing, John, is with some of the changes from just a regulatory perspective. You have health system executives and physicians, maybe the same, that are working diligently just to figure out, hey, how do I solve my Medicaid issue? How do I address the care that I'm delivering already? And it's overwhelming, thinking about labor, thinking about reimbursement models, but no one is making independent physician care easier. No one is offering more money. And so it is a struggle to kind of think through these innovative ideas while you're also dealing with the real world on the other side. And I think we're seeing some excitement, though, that's being generated. We're actually seeing some value, some cost savings, some improved outcomes in care as these models really kick off and get implemented. So exciting times for sure.
It's funny because that same administrative group, the executive team that is just inundated with issues coming at them from every different direction, one of the things that I would say to them is when those problems involve how you reach out and care for patients, turn some of this over to physicians.
Yeah.
You've now got a vehicle through VBE that allows you to pay physicians for solving problems, for the outcome of solving problems, instead of just for the inputs of their time or work reviews or whatever productivity measure you're going to use. It's a great opportunity to really change the dynamic. If I was cynical, I'd say all those physicians who complain to you all the time, congratulations, solve the problem for us, right? Physicians really can be helpful, and it can come in really unexpected ways, right? Your flow through the ED, you got folks boarding in the ED waiting to be admitted upstairs. The hospitalists and the ED docs won't communicate, won't cooperate. Hand it over to them and say, this is what it's costing us in terms of patient care, in terms of dollars, in terms of opportunity. You solve it, you share in the savings, you share in the results. And so really just fabulous opportunities.
Well, and I love the way that you frame that because, one of the things from my work and working with physicians that I've always heard is, John, one of the challenges is that we didn't feel like we had a seat at the table. We felt like we were on the menu. And so if I understand you, it's allow physicians to be owners, allow physicians to really be empowered to make those decisions and drive that change, because at the end of the day, they know how to do this. They know how to take care of patients. We've just got to pull some of this stuff out of the way to allow them to engage with patients. And so I think as we transition a little bit more to the practical application, what excites me is looking at this through an operator's lens. And so I know we're going to talk a little bit about team. We're going to probably look at a service line VBE because of the work that we do in ortho and neuro and cardiology. But before we start talking about kind of the fundamental roadmap and some of the elements to build this, is there anything from of a high level that maybe we haven't covered or things that you think might be beneficial to set the framework before we take a little bit of a deeper dive?
John, I don't know. We've hit on a number of different topics. I mean, I think just to kind of go back a little bit, I think don't assume that any issue is too big or too small. So I think being open to the ideas, I think we've talked about, we've complained, we've tried to solve some of these issues in the past with different tactical models. I think this gives us just a different approach and a different level of regulatory consideration that we can support. So I think you've got to get governance right. I think you have to get comfortable very quickly in sharing information that's not just clinical. So what does the financial considerations look like? What are some of the costs associated with delivering care that you want me to help you solve for, but I don't know any information and I don't know why I should believe that information. So thinking through that, I think having operators at the table and not just executives or not just physicians, but having the individuals that have the ability to report that information and the operators, that actually live this day to day, I think is critical to success.
Yeah, and I would say probably beyond the scope of what we want to talk about. We want to talk about the practical application and kind of the why and the strategy. But we do need to keep in mind the details of the regulatory framework. They are broad, and when you check each of the boxes, you have tremendous freedom, which is what's been kind of the angst that we've had. I can do anything I want. But the regulations themselves do have a framework, and it isn't a free-for-all. And you can do anything you want to improve patient care, improve care delivery, reduce the cost to payers, transition to volume. You can do whatever you need to do to achieve those purposes, but there's a framework that's set out on how you do it. And there's some pretty important details in that framework that if you miss, you haven't complied with the Stark Law regulation. And so really you can bury yourself down in the details. Nobody wants to do that except for a handful of us, but the details end up being important. And I think what we struggled with is how to apply it, not those details necessarily. But as people get excited and start, then you turn into, when you're a hammer, everything looks like a nail. I have health systems that are saying VBE, 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 right? When you get to that point where we really see the possibilities, it's important to step back and say, we've got to have a process for making sure we check all the boxes, because this is it's a bet the farm type of a situation. If you change your engagement with physicians, start paying in a way that wouldn't have been permissible under the old rules, and you're not fully complying specifically with all the details of the new rules, you've got a pretty significant compliance issue that you're building up.
And I think that goes back to the compliance component in the monitoring process, right? So as an example, if you're not hitting the intended purpose, that in and of itself isn't a problem. But if you don't course correct, that's the problem. You have to monitor the process. You have to ensure that you're making the right movement for those outcomes. So you want to start necessary movement, but that monitoring process from a compliance perspective is to pivot and to change if it's not working, if you're not getting the desired outcomes.
It's a perfect example, John. The regs provide for 3 different tiers under the Stark Law. You can have a full risk, you can have meaningful risk, or you can have no risk, the care coordination. And the rules for monitoring and course correcting are different in each of those. Right. And so if you're not paying attention to the details and you've started a no-risk care coordination VBE and you don't realize that you have to take metrics and activities that are ineffective and change them within 90 days, you've blown it. And so there are some details that really matter. That's not where we want to spend our time today. But to answer your point, what are the big picture thing that we should focus on before we move on? One of the big picture things is don't forget the details.
Well, and I think also don't forget the accountable aspect of this. I mean, it's easy to kind of outline some metrics and say, hey, let's get together once a quarter. It's also a very different environment where you say, hey, there's an accountable body that's going to evaluate, monitor. It takes different sizes, different shapes for every entity, but it really is important to kind of keep that forefront. We don't hold ourselves accountable enough about the care being delivered across our organizations, and how do we elevate that using this model is really critical.
Yeah, and say it again, don't shortchange your accountable body. To pick up on your comment there, it's where you can really concentrate a lot of resources. You can concentrate the governance process. That's what it's designed for. And I see draft documents from other sources that they shortchange the accountable body. They provide no definition. They don't think about who should be at the table. It's an important piece for compliance and really for achieving your goals. If your goal is not only to be compliant, but to actually change the way care is delivered and meet one or more of those purposes, you're not going to achieve it if you don't have a strong, accountable body that's monitoring and pushing for results.
So, I think this is a great opportunity to look at some of the exciting things that have come down the pike, right? So when you look at the team model, as an example, I look at team and I look at track 1, 2, 3, and then I look at VBE and I look at care coordination, moderate risk, and full risk, and it's almost a perfect alignment. I think people had mixed emotions because it's a mandatory model. We didn't know if it was going to move forward, but July 31st, the final implementation changes have hit. The final rule is set, and this is something that will go live on January of 2026. It's going to encompass about a quarter of America's hospitals. We're talking, I think it's 746 hospitals across 188 CBSAs. So some of them have ACOs and SINs, and some of them don't. And so what I think is a great opportunity to look from a structural perspective into a VBE and a roadmap for success would be to look at some of those different initiatives. There are 5 episodes within Team. I think we could certainly break down each one of those. But for me, probably one of the more complex is spinal fusion, because now we're looking at not only how we bring in operators, but how we bring in our ortho service line, how we bring in our neuro service line, and how we get them to work together towards a desired outcome. So if it's okay with you, maybe we take that one as a little bit more complex. Let's look at a service line VBE and let's break out the roadmap. So from your perspective, how do you define those strategic objectives, the outcomes, identifying participants? What does that look like? Just the initial phase of that conversation.
Well, I think you can leverage the regulations that have been laid out with Team. So let's start at kind of a preliminary stage and first of all, download the list and see if you're on it. I think we have a number of clients that we speak to that have no idea, frankly, that they're on the mandatory list and that this is going live in 5 months. This is real. And so I think understanding that, it does break down the way each of those 5 categories are defined. So we have the ability to pull codes. We have the ability to define that patient population. It is kind of a scary yet exciting time to think about, how do I get my orthopedic surgeons, my neurosurgeons to work together? But now let's include PM&R, radiology, and think through my rehab team.
Pain management.
Pain management, yeah. How do I get kind of that full complement involved in the process, I think is critical. So I think starting point is just let's sit down, let's define who's involved in these cases, let's involve and ensure that we understand the regulations associated with team, and then really make sure that we have the right people around the table.
Yeah, I really, I would agree with both of you, and want to stress for everyone we talk to on this subject that you really should sit down with the framework, the guidelines about what's in team, and what the VBE rules say. The crosswalk is pretty amazing, and so this is a perfect opportunity to use VBE to try to really boost your performance in the team program. And you're going to participate in all 5. But, for us, we did a spine VBE program together, and it really is a great opportunity. Looking at the leading up to when and why you take someone to surgery, how you actually engage in that episode of care, and then how you come out of that episode of care in a way that's really proactive and keeps the patient on the right track. It's just a perfect storm.
Well, and I think if you guys have recently built one, I'd love to hear a little bit more about that success. So when you look at the desired outcomes, like what was that process? Like, how did you determine the clinical improvements? What did you look at from financial efficiencies? How did that impact the patient experience? Like, what was that process?
We made the physician whisperer go into the boardroom and try to do his fancy footwork to get everybody talking, and that really is the first step. Get everyone talking, and time's running out. Anthony just mentioned 5 months. We're going to beat it to January 1st, and this program is going to go live. I hope none of our clients are in the bucket at that point of not realizing they're in the program, but there are a lot of hospitals that don't realize they're in the program just yet, and they need to get started. And if you're going to partner with physicians, you've got to talk with them. You've got to switch from them being on the menu to being back in the kitchen with you.
Yeah, Jim mentioned it, and we lose sight of this. We talk about communication all the time, and yet we don't know what it means, and we certainly don't do it. So bringing those individuals around the table, getting them talking about their daily frustrations, what would lead to a complication, what would lead to extended stays beyond what is normal and what is kind of standard delivery of care across the United States. There's certain pockets that you would say, hey, that you should be doing every spinal case, maybe not every spinal case, but every spinal fusion in a outpatient or ambulatory surgery care model. And what does that look like? How do you get to that level of care when you're starting from a average length of stay of 1.8? And so I think transitioning that, but having that communication about, frankly, what's working, what's not. What tools do I not have in my belt that allows for this to actually be successful in having that dialogue?
And it ends up sounding, as we describe it, I'm listening to you, and it ends up sounding like touchy-feely, like we're going to have an intervention and
kumbaya.
Yeah.
A group.
Sometimes we have both.
A trust fall, and so what ends up happening though is people get that out of their system. They start to actually communicate. They start to clarify. Half of what they're upset about is just misunderstanding, a lack of follow-up. And so when you say what are the key components, it's getting started on that communication, trying to repair some trust that's been lost. It's assigning, typically it's hospital staff, to be a designated, ongoing, kind of permanent piece of that VBE process so that you have continuity from meeting to meeting. You're actually following up, whether you use consulting help to get that started. Eventually you have to take that process over yourself. The one we worked on The service line manager was, I mean, they need to bronze a statue of that woman.
Yeah.
Amazing. And so she would make sure from meeting to meeting, Dr. So-and-so said these should be the metrics. I went and met with him. We really hammered him out. I've got a numerator, I've got a denominator. And by the end of the meeting, he decided some of those shouldn't be on the list. That kind of process, doctors then realized, the physicians realized that you're taking them seriously. They are integrated in the process and they will be listened to. It's amazing what physicians will do if you actually listen and mean it.
Yeah, creating the iterative process, right?
Yeah.
And, you know, it's an interesting sidebar. One of the things you hit on when you talk about the outpatient setting is in the final rule that just launched on July 31st, in Performance Year 3, I believe, for the outpatient, patient-reported outcomes is going to be one of the criteria. And so, you know, how are you addressing the patient experience? How are you addressing the outcome? So looking at the service line VBE that you all created around the spinal fusion, how did you establish the governance structure? Like, who was involved? What does that process look like? What were those different titles? What was it?
Yeah, in this particular example, we had two surgeons. We had the administrator, the president of the group, which was a non-physician. We had the health system CEO. We had the president of the largest hospital within that health system, and then we had the service line leader that was part of that as well. And then we supplemented that with committees. So we did have discussions happening, meetings happening between that executive committee and each of these respective committees. There was also ongoing communication. So emails, actual meetings, work being done just to gather information. We didn't start with all the information. We didn't start with the metrics. We didn't say these are the items that I'm looking to solve immediately. We had a chance to sit down with the physicians and talk with each of them individually and as a group and saying, hey, if you were to name 3 items that you want to fix, what would that look like? So we got commitment from the highest level. We don't cancel meetings unless we have someone that's out of the country, and then we look to reschedule versus canceling. But we have ongoing communication in between those meetings, which has been absolutely critical and key as we walk through the process.
You know, I think about your description there, and I think about team and this program. On the one hand, you know what the metrics are going to be, right? They've been published at this point. I wouldn't say, though, that you're done because you haven't unpacked that in the process improvement, Lean Six Sigma kind of methodology. You haven't unpacked that to say, what are the components that you're going to, the activities, the initiatives, what are the pieces that actually lead to that outcome? And so that's an important step, and one the physicians can be really helpful in. If we're looking at, 30-day readmissions, what leads to a 30-day readmission? Starting to unpack that and come up with activities that are going to achieve that outcome is really an important process. I would say far too many VBEs are started with just a general idea of the direction they're headed without the level of detail that this one we worked on together. That service line leader and the physicians, quite frankly, really put in a lot of time before day one. The lead up to day one was a lot of work, but they came away with a set of criteria, metrics, and measurements, and down to numerators, denominators, sample reports. Another great piece of advice: get your IT department to run the reports before you ink the VBE. If you can't actually run a report on what last quarter would have been, how are you going to run the report at the end of this quarter? And so a lot of pre-planning and communication and really putting down on paper the details you need to be successful.
Yeah, no, I think that's a great point. And it's interesting because one of the other things is you look at why CMS decided to pick these 5 episodes, because they're high volume, they're high spend, it's similar care pathways, and there's a lot of variability in expense, mostly in the post-acute, right? And so when you talk about participants and you talk about what causes a 30-day readmission, I think about transitional care management, which is one of the reasons there's a requirement and mandated that it has to be referred back to a primary care provider. I think about SNFs and some of the things they've done with the 3-day waiver and being able to move into swing beds, so it helps with the rural communities. But that brings in not only new participants, but then understanding all of the elements that make up that readmission. using that as a guide, how do you just select and design performance metrics? So maybe from a clinical perspective, are we looking at what those quality outcomes are? Are we looking at patient satisfaction? Are we looking at, potential complication rates? Are we looking at, O to E? Like, what does that process look like from a clinical perspective?
Yeah, I think all the above is the short answer. So we do look at HOOS, we do look at COOS, we do look at the ability to say, let's understand those patient outcomes. Yeah, I can't tell you the number of meetings we've all sat in. I'm sure that physicians say, well, what does patient satisfaction have to do with patient outcomes? And yet, in these episodes, we're talking about HOOS and COOS metrics that are patient-reported outcomes considerations. So involving that patient in the care and the outcomes and the reporting of that is important. Thinking through, we always start with a much larger list than we ultimately land on. So let's understand the biggest opportunities. Let's understand, to Jim's point, what do we have the ability to define, to include the numerator, denominator, and actually get a report before we launch. You don't want to find out 6 months from now that I can't report that. But we have a situation right now with a VBE that, they didn't go through kind of the homework on the front end. They jumped in. They knew what the problem was. They wanted to fix it. We're still waiting on data to be reported a year later. And the frustration that's growing with the physicians is real because I can't get income or any inputs and information. I've given you my time. You asked me to show up for meetings. The agenda is poorly planned. The outcomes are not available because I can't run a report. So we sit around, we talk about a lot of things, but what that does is it wastes everyone's time sitting around the table. It's an expensive table to be talking about things that we have no ability to interject. So again, I think when we're talking about metrics and developing them, and it really is starting with professional societies, registries, conversations with physicians about on those professional society registries, what they do and do not value as outcomes and patient process considerations. We're not just talking about clinical outcomes. We're also talking about process. We're talking about projects. We're talking about the whole episode of care, which is also not just the cost of the DRG, which I think is frequently overlooked. We have the ability to run a bunch of cost reports on a DRG, but I have no idea once I leave my hospital what the cost of care was before you arrived at my hospital or what it was after. That's what we're talking about with the episode with team. It's the full cost.
Right.
So
anchor stay through.
It really is. Yeah. And thinking through that is unusual and it's unknown. And for some, they have that information. They've built their network, but many, they have no idea where to start.
It's a good point, Anthony, because I think a lot of this is not coming up with some secret sauce. I'm coming up with some metrics or something that's unique that no one has discovered yet. A lot of times we've got some pretty straightforward answers to some pretty clear problems. Process creates outcomes. You can't just use outcome measures. The team model uses outcome measures. But we have to create process measures and metrics that lead to that. And sometimes it's really simple. I mean, we know there's a BMI over which you should not be taking a patient to surgery. We know we should be looking at smoking cessation. We know that you should be, on the spine example, you should be going through pain management. You should be going through physical therapy. There should be a care pathway. And yet, I've sat through lots of board meetings, hospital board meetings, where the report out from the MEC quality is saying, this doctor hasn't followed any of those care pathways. There's no consequences to that. You can now have the ability to build a model that pays consequences for that. And so some of this is basic block and tackle, but it ends up being a lot harder to manage than we've been able to get our arms around. Now you're gonna get paid on the outcomes. You really need to spend some time, as Anthony's describing, making sure you're figuring out what the process is that leads to those outcomes, measuring them and paying on them.
Yeah. Yeah. And so if I understand you correct, it's looking at the process and identifying the things that are going to create the outcome, from a how do we align clinical with financial and operational. It's understanding what we can measure and then using that to justify the work that we're doing. So if I'm a CFO in the room, right, one of the things I can certainly measure is episode cost. One of the things I can certainly measure is cost savings from preference pack and standardization, right? One of the things that I can measure is the cost of readmission, right? And so building those kind of outcomes from a quantitative perspective, but from a qualitative perspective is what are all the things that are going to make that process come true at the end, and who needs to be brought in to ensure that all of those things are happening.
Yeah, it's frustrating to the point of being maddening for physicians to be told, here are your outcomes. They're not as good as others. What can you do about it? We really need to engage with physicians and give them, first of all, more data, more help, more participation, and then more authority to actually make changes. So, you'll get my patients are sicker. You'll get a bunch of answers about why. You need to work through that process and come up with ways of measuring it over time to give answers on what's really happening here.
Yeah. And it's interesting too, because when I look at the VBE framework and I look at a lot of organizations that have tied, let's call it roughly 10% of physician compensation to quality metrics, and some of that's been, participation, stewardship, and
stop paying for showing up for me.
Now we can actually align this with true value-added quality metrics that lead to true, tangible, definable outcomes.
And I would say that's where I would add, and you can go further. We had some models that we could pay for quality outcomes in the past. You can go further and pay for the process that leads to quality outcomes, right? The commentary to the regs, the OIG used an example in a cancer imaging example that said the MEC decided that from a quality standpoint, dual modality was going to be better for diagnosing this cancer than a single modality. And they suggested it would be an appropriate VBE to pay them $10 per referral, per order for the dual modality instead of the single. That's blatantly illegal under the old model. You can't do that.
All the tiny spider senses.
Yeah, everybody's hyperventilating. Not only can do it, it was an example in the commentary to the regs from OIG. You really need to wrap your head around, I'm going to ask the doctors what would lead to a better outcome. We're going to define it specifically, and then we're going to pay them for following that process. And the outliers are going to lose money.
Yeah. So sort of that same vein, then, if I'm looking at how to create efficiency, I'm looking at how to create better throughput. Is that an example where, as a hospital or a health system, you could provide APPs to help support those physicians both pre, during, and post surgery? And I mean, in essence, that could be an in-kind perk. But under a VBE, does that allow for you to be able to provide those services to create that efficiency? Is that some of the flexibility in the model?
Yeah, there's definitely flexibility in that regard. Back to my point earlier, you really have to have someone involved that knows the details of the regs. So, and you have to have an understanding. Are you comfortable with the Stark exception being primarily what you're relying on, or do you need the Stark exception and the anti-kickback safe harbor? And so the anti-kickback piece of VBE is a little different is clearly different than the Stark piece, and it can be more stringent. And so, in that case, the example you use with APPs, we've had clients that want to at least check as many of the AKS boxes as they can. And so you may have physicians paying, say, 15% of their share of those APPs. But there's lots of ways to structure it.
Sure.
And the underlying answer, which is important for our discussion, is yes, those types of resources like APPs, whether they're in the clinic, whether they're rounding, whether they're surgical assists, that type of help to do better care coordination, to do better outcomes, to help create a system where you really understand how you'd move from value-based payments model to a volume-based payment model. That's permissible, not only permissible, encouraged under the system.
Right.
The issue with the APPs, though, only because there's a couple pretty significant cases that are out there around the APP consideration, is don't make up the facts. Define them specifically. What are they going to be doing? How are they going to help improve the value of care? What's their role? What does the physician get in return? Do they just get better patient outcomes because the APPs are part of the entire system? or are they getting some of their benefit? And I think just being honest about what those benefits are to ensure that you're compliant, which I know we all just probably subsequently roll our eyes. That's not the purpose. The purpose is to say, let's be factual. Let's be honest about how we're going to use them. How does it contribute to the care and make it better?
Yeah, and the details matter, right? So
details matter.
You put in place this APPs is obviously a good example, and then you let the physicians somehow bill and collect for that work, and you're paying their salary. I mean, you can create facts that are going to turn even the best intentioned or obviously good for patient care situations into something that's questionable and hard to defend. So the facts matter, but the system does permit, VBE does permit you to add resources to the physician's delivery of care and have the physician not necessarily have to pay for those if the purpose of doing so is to improve patient care, improve coordination, lower the cost to payers, not your own hospital cost, but lower the cost to payers, and create a system where you're exercising those muscles that you're going to need to take on risk in the future, move to value-based payment models.
And I think it matters which risk category you're under, too, in terms of the flexibility that's allowed.
It really does. So back to the earlier point, the requirements on the no risk, where the physicians aren't going to lose any money if they don't do what everybody says we're going to do. That has the most stringent requirements in terms of monitoring and adjusting and proving. I mean, you still have to prove commercial reasonableness. You still can't tie it to the volume and value of referrals in any way. So it's an important distinction that each of those risk levels, as you take more risk, kind of the requirements seem to fall away. If you're full risk, you can, game over. You can, if you're taking full risk for the payments, you can do what you want.
Well, I think commercial reasonableness probably still elevates, right? I think that is certainly from a standalone lens, something that needs to be considered. But, what's been great is kind of we've gone through this process and we've talked about kind of how we built it from the ground up. So now we've identified the participants, we've looked at the processes, we've looked at the outcomes, we've figured out what can be measured, what can't be measured, how we track, how we pivot, how we continue to improve. So now how do we design and implement the payment mechanisms? So, what does that look like from shared savings? If I am full risk and I'm partnering with post-acute and I'm looking at SNF to help reduce that readmission, they've got to have skin in the game too, right? So how did you guys structure those arrangements to ensure that pot was being divvied out correctly and that everybody had risk and shared skin in the game?
Yeah, that's kind of next level that we're seeing across the country, and it gets back a little to the ACO models that we tried to work on a decade ago to get folks down that path. When you start to include, if you're at full risk, if you're in a full risk model, and there's very few of them, you have a lot more freedom. Most of us are operating in that meaningful downside risk or the no risk, and so including the upstream and downstream partners really has to be well thought out. It's extremely important to the success ultimately of being able to move to taking risk and value-based payments. But it can be hard, John, to get those folks on board and get them in. I would say that for us, most of our clients, we've tried to encourage, move forward with what you have control over. Don't wait for perfect, right? Let's get started making improvements. Let's create the framework for that. And then you start adding in these other components as you move forward. So it's a much bigger project when you start adding in all the ancillary pre and post-acute care services. So
build success and then kind of increase the complexity.
Yeah, that's not to discourage you from working with third parties and outside partners.
I think it's imperative. You have to.
Yeah, and they're clearly contemplated by the VBE regs. I would just say that for most of the country, just shifting away from the old Stark Law requirements into this new VBE model that relies so heavily on actual performance, not a thick file of fair market value, but the actual performance. I think we're still at a stage where that's enough of a lift for most health systems.
It really does come down to the data that you have accessible to you. So, with the team model, you have data that's recently come out. There's been debates about the accuracy of that data because that's the first defense, right? Is let's just beat up the data itself. But then trying to figure out how do you mirror that? How do you monitor it? How do you know if you're making progress on each of these episodes, especially for those items that are happening outside of the four walls of the hospital, is debatable and open for discussion. So I think really being wise about how you coordinate and how you organize that data, number one. Number two, I think as you monitor performance and you say, hey, by reducing a complication or by reducing a mortality, what is that worth? What does that look like? How do I create a system that allows me truly to demonstrate that value? Then I think to your point or your question, John, is that then becomes kind of how you define what the value or the payment is made back to the providers or back to the physicians. There's gain sharing alternatives, there's shared savings considerations, there's a percentage of the savings that's going to be accomplished. There's different ways to structure that and do it. It's not a free-for-all. It's not just this random, hey, I have to make up this amount, so let me put that amount in my legal document, or let me put that amount that I'm going to pay back from a compliance perspective. That's the tactical piece. Strategically, it's how do I get that alignment behind sharing some of that savings back to my physicians?
You know, hearing you say that, it reminds me, and Pinnacle does valuations for lots of our clients.
Sure.
And we are seeing valuation firms get more comfortable with tailoring their valuations to VBE arrangements. And so I think that's an important piece for folks that are considering moving in that direction. You don't have to give up getting a valuation. The nature of that valuation may change as we've switched from valuing inputs to valuing outputs. It's really helpful to go, I mean, even just for a good check on what the rest of the country is doing. I had a mentor once tell me that, good business is good compliance. Coming to Anthony and saying, hey, what are people paying in general for a spine fusion program, a center of excellence program that has these characteristics, this volume, this number of doctors, these criteria, and getting a number and having then Pinnacle or others say, and here's generally how we see that allocated across the system. But they're not coming back and saying you can pay $205 an hour to this specialist, right? They're coming back and saying this program would generally be a $2 million program, and we'd see this divided up amongst these categories. That really does provide you some guidance without necessarily being a bludgeon or a straitjacket. So I think it can be really important. The other thing to keep in mind, sorry, go back to the details of the regs again for a minute, but it isn't a free-for-all. You cannot pay anything you want. When we say you no longer have to prove up fair market value, you may, if your risk level is high enough, not have to demonstrate commercial reasonableness, and you may not have to avoid any connection to volume and value of referrals taking into account. That doesn't mean, and I've heard health system leaders say it, I've even heard other consultants say it, that sky's the limit, you can pay whatever you want. That's not true. The reg says specifically the payments must be for or from the result of the activities that you've asked the physicians to engage in. So you have value-based activities for a value-based purpose for a target patient population. You have to be paying for engaging in those activities or paying shared savings, the results from those activities. If you're paying so much that you can't pass a straight-face test on, yes, this is for that, you're going to fail. And you are putting a lot at risk in that model. So where you don't necessarily, the burden isn't on the health system to prove that it's fair market value, that's a huge step forward. To say then that you have no constraints is ludicrous.
Yeah, I think that's a fair point, and an interesting one at that. In fact, we could give a whole another segment on some of the questions that we're getting just from our compensation valuation team around some of the final rule changes and what that means for the RVU, from the efficiency adjustments to the two-tier to the et cetera, and like, how does that work and what does it mean for quality and what does it mean for potential comp design? We could have a whole nother conversation on that. But I think, I believe it's actually you that I've heard say this, is that you're trading the compliance checkbox today for a promise tomorrow. In other words, that's the monitoring, that's the compliance, that's the process improvement, all the things that you're doing through the process are really where you're proving what you're doing is successful than to just say, it used to be at the front end, like, hey, let me get an FMV, make sure this is commercially reasonable, let's document, let's check the box, let's file it away, let's go.
Yeah. And all of us have experienced this. The number of times I've been in situations where we intended to do one thing, and at the end of a reporting period, we hadn't measured, we haven't kept track, we don't know, we didn't even get started. Year on, we don't have metrics. The number of times I've been involved in that is startling, and that's a huge risk under a VBE, because your entire compliance model is built on, your entire compliance position is a future promise, not it's fair market value, it's an isolated transaction, it's whatever exception you're gonna rely on under Stark, that you've got a folder that you can prove it, and it's kind of time bound, and as long as I don't deviate from that dramatically, I'm okay. VBE is a fairly thin file and a future promise, and so if you don't actually implement it, and that's something we struggle with as health systems, the follow-up and the implementation. We have so many things coming at us. It seems like, the entire campus is one big Rube Goldberg machine with parts flying everywhere. That's a tough environment to really keep track of the details. And that's where compliance comes from in a VBE, keeping track of the details.
I know we've covered a lot. and hopefully, if anything, this gives some tangible takeaways, really helps to spur thought around what it takes to be successful, the way in which you should be looking at this framework, how it can be implemented specifically for some of the more mandatory models like TEAM. We didn't even get into some of the things that are supposedly coming in 2027, like the ambulatory specialty model, where we can get into low back, we can get into heart failure. There's a lot more models that are coming, and what's exciting to me is that we now have a framework to innovate, whereas before I felt like we were a little bit handcuffed. We were operating with one hand behind our back. Now, in essence, the gloves have come off, and as long as we follow the rules and are doing things the correct way, we have an opportunity to innovate in a way that we've never been able to do before. So this has been a phenomenal conversation. I truly appreciate you all taking the time to visit with us today and to share this information with the audience. In closing, any final thoughts, any great takeaways, anything that you think would resonate that we haven't covered, or something that you'd want to leave the audience with? Anthony, I'll start with you.
Yeah, I think the biggest takeaway is don't talk yourself out of it. So either because of the lack of clarity from the government, or you think it's going to be work, it is going to be work. It should be work. But the outcome and the futuristic output of that innovation developed from a VBE preparation for TEAM and ASM and all these discussions that we've had, for years, about low back pain, about congestive heart failure, about outcomes of some of these major initiatives around CABG and lower extremity and spine fusion, all areas that we should be addressing on a regular basis. So I think the key is start the process. Let's understand what you need from a roadmap perspective, and then operationally implement.
Yeah, and I'd say first, in picking up on what Anthony's saying, the outcomes that you can achieve when you no longer are restricted to only paying physicians for their inputs, whether that's work RVUs or hours spent or any other the old methodologies we used, when you can switch to paying physicians for outcomes, the outcomes you can achieve are dramatically bigger. And so for our health systems that are reluctant to go there because they've heard all this nonsense about VBEs being this free pass, it's not a free pass. You have to pay attention to the details. The details matter. It can be a huge risk if you don't do it right. On the other hand, VBE is real, and the possibilities are amazing. And so our best clients, who are the least likely to want to take risk, are the ones we really should be encouraging to look at VBE. They have the most to gain. They're the best situated to implement it well. And when you can switch doctors from being just sitting in a cubicle producing widgets to instead leading the redesign of care delivery, you have got something amazing.
Yeah, absolutely. Well, again, thank you so much for taking the time. I think the takeaway is start the movement, right? Start looking at how you can innovate. This is not something that started yesterday. VBEs have been around for a number of years now. The law of diffusion of innovation, we are quickly moving into the early majority, and it's only a matter of time before we get to the majority. Let's move healthcare forward together. Thank you so much for joining us on Perspectives with Pinnacle. You can follow us on Spotify, Apple Music, or on our website, askphc.com. Thanks again.
Pinnacle is your partner in the business of healthcare. Nationally recognized for helping clients manage risk, improve performance, and drive innovation. For more information, visit our website, askphc.com. For more information on our guest, Jim Burke, or to learn more about Hall Render and Hall Render Advisory Services, please visit their website, hallrender.com.